Good to see you. You're probably working today. So can you unmute yourself, please?
Hi,
Yes.
Mirza.
Yeah, just
Mirza.
unmute yourself.
Hi, Mirza.
Mirza just joined. He's
Hi, can everybody hear me?
Yes,
Yes.
Good,
Okay.
wonderful.
Hi, hello everyone.
Hi.
I'm very sorry that I came late. I was in the
No
OR.
problem, no problem.
No
You're
problem,
just,
man. No
You're just in
problem.
time for your
Okay.
lecture on graft-related complications.
Great.
So
Then I'll just
tell us about a little bit about you and proceed to your presentation.
Yes. So wait a second. You just have to switch me on so that I can share my screen.
Oh, you're not.
I'm
Yes,
here as
yes.
a participant.
Already.
Okay.
Can you now do it?
Yeah.
Yeah,
So,
yeah, okay.
Can everybody see this?
Yeah.
Yeah.
Okay. Okay, great. So, hello everyone, and thank you for the kind invitation to this webinar. And sorry for being late. Working day in the OR just about now. I'm going to talk on graft-related complications of anterior cervical surgery. My name is Mirza Pojskic. I'm assistant professor at Department of Neurosurgery in University Hospital Marburg in Germany. We are a department which is very famous for introduction of modern technologies in neurosurgery, such as augmented reality, neuronavigation, robotics. So that is my primary scope of interest in spine and in cranial neurosurgery. But I also do a lot of spine cases, also anterior cervical cases, and I'm going to talk today on graft-related complications. So generally, complications in spine surgery that are surgical related and systemic. Intraoperative complications, recognized cerebral fluid, active bleeding through malposition. Not recognized intraoperative complications, so-called CSF leak, compression of the spinal cord, or dural seg due to incomplete or inadequate decompression. Postoperative, early and late. And there are various complications such as infections, implant failure, dislocation, pseudoarthrosis, adjacent segment disease, and that's what I'm going to talk about today. Then we have non-infection complications, specific complications of anterior cervical spine surgery, dysphonia, dysphagia, C5 paralysis, vascular injury, and systematic complications. One disease which we need to be aware of and which is on the rise, especially in the Western world, in Germany, is spondylodiscitis. So postoperative spondylodiscitis, every time, especially for the young people who are listening to that, if you have a patient following surgery, anterior cervical surgery with a swelling, with redness, with fever, with high infection parameters, that is you always need to rule out spondylodiscitis of any kind of wound infection. So I just first wanted to clarify a few important definitions which we need to know prior to talking about graft complications. So what is fusion? Fusion is defined as the presence of trabecular bridging and or absence of motion between the two bony segments which we fused. And the fusion can be achieved either with screws or with cages or with wires before. And in a large series, it is accomplished in 90% of patients in 1 year following ACDF. However, there is no gold standard to assess, and it could not be derived from all the systematic reviews which we have. Addition of plates and cages with screws results in a slightly higher accomplishment of fusion, but the differences are not clinically relevant. And fusion is less in multi-level surgery. So if you do more segments, the fusion will be less. Smokers and diabetes, as well as in patients who receive vertebral body implants as compared to those with cage. So pseudoarthrosis is a failure of fusion after an index procedure intended to obtain spinal arthrodesis. And in cervical spine, it's actually an adverse event which occurs when a surgically postoperatively and account for up to half of all revisions. It's lower in posterior procedures than in anterior. It's lower with plating. And in the last 20 years, there is a use of recombinant proteins, such as human bone morphogenetic proteins, which is thought to improve fusion. So the early results have shown that, but also higher complications, for example, neck swelling and other complications. But recently, in neurosurgical focus in 2021, we have this study by Mendenhall, which used low-dose protocols of these proteins in smoker in multi-level fusion to improve overall fusion that has shown good result. So these are some clinical examples of good fusion. You have here status post ACDF with healed bone within the spacers, and this is actually how it should look. And here you have on the left side and on the right side cases of non-fusion. And you always see non-fusion in a way that you see the ground plates of the vertebrae always look kind of harassed or infected. And there are no bony bridges between the implant and this segment has too much motion. And in that way, patients remain with pain. This is also a very good example from one publication. You see that the scans is A, C, and E, how the fusion should look. And the scans in B, D, and F is actually an example of pseudoarthrosis. You always have these osteolysis, or the so-called holes in the bones just near to the implant, which then results in pain and various diverse complications. Subsidence is another term which is important when we talk about graft-related complications. It's generally defined as a reduction in the anterior posterior disc height, which is greater than 2 or 3 millimeter during the postoperative period following ACDF. It's common occurrence. It occurs in up to 40% of patients. It's associated with segmental orthosis loss. And one of the factors which leads to subsidence is over-distraction, because with the over-distraction, we tend to implant larger cage than the patient actually needs. And then afterwards, when the over-distraction is over, the intraoperative over-distraction, then this cage subsides in the ground plates. Further risk factor is multi-level fusion. As for subsidence and pseudoarthrosis, while subsidence by pseudoarthrosis can be a possible clinical problem, we have a lot of patients with subsidence who don't have any clinical problems at all. And that is very important to understand, that not every subsidence is itself a worrying event or event where you need to revise your patient. So when ACDF became a well-accepted procedure in the 50s, now we're talking about graft types. We first had the autologous bone grafts, which were obtained from the anterior iliac crest. But this technique has a large morbidity of the place where you take the implant out, but it is very cheap on the other hand. So that's why in the Western world, in Europe, and many other middle and high income countries, we've moved to synthetic cages, which replace the bone grafts involving synthetic materials: stainless steel, titanium, carbon fiber, polymethyl methacrylate, and polyethyl ether ketone. And these artificial cage types have the ability to restore and preserve the disc height and lordosis, and the ability to prevent graft collapse or resorption. And big systematic reviews have shown that patients treated with cage screw combinations had less subsidence than patients treated with PEEK or PMMA. So this is an example from our practice. This is a patient who fell from the height of 2 meters under influence of alcohol, obesity, high blood pressure, severe pain on the cervicothoracic junction, had in the external hospital justice X-ray. We've performed the CT, where we have shown that he has actually a bilateral pedicle fracture, so a highly unstable fracture. And we have decided, due to the involvement of the disc, to operate this patient primarily from the anterior. We've put a vertebral body implant, which has winged screws, which are not seen in this video, in this picture. And the patient mobilized himself very early after the surgery, fell down, and this is one example of the very few very early post-operative hardware failure and knockout of the implant. He then had an epidural hematoma, and then was revised from posteriorly. So one of the good strategies, if you have an implant failure on the front, and the anterior cervical surgery, is to do an additional fixation from the back and as a 360 fusion, and then can stabilize the entire construct. This is a patient which had rheumatoid arthritis and the so-called staircase deformity of the cervical spine, received an extendable body cage, which then collapsed very early after the index surgery. And she then underwent an additional corpectomy with additional vertebral body cage and a plate, but also this construct failed on the lower end of the construct again, although there was a plate. So then the patient received, as an additional surgery, a posterior fixation using an intraoperative CT, but also with a posterior fixation, the cage or the vertebral body implant collapsed again. So in the end, she got a very traditional mesh cage, which is actually not a very expensive implant, and which you can cut in the surgery according to your defect. And she's now with this implant stable and surprisingly without high-grade neurological deficits. One take-home message would be to be very careful with these vertebral body implants, especially if you have a larger amount of bone to surpass or multiple levels or corpectomies. We have become very conservative when it comes to indications for corpectomies and in several levels, because the rate of implant failure is actually very high. And in implant failures like this, patients can have loads of trouble. They can have a neck swelling, swallowing problems, injury of the esophagus, and dysphonia, dysphagia. And usually a lot of these problems then remain for a long time after the revision. Yeah? There are, of course, implant failures in cervical spine on the back, for example, here with a screw breakage and the screw loosening or removal of the screw from the rod on one side in cases of instability on the craniocervical junction. There are also cases of occult esophageal injuries. For example, in this case, this is a patient which presented with very progressive myelopathy signs following a fall down with a spinal canal stenosis, who had then 3-level ACDF and the plating. And the patient developed then very soon after surgery septic shock. He had a swelling in the neck. You see here ventrally from the cervical spine, one large hematoma, and this patient then had actually an occult esophageal injury, which was not seen during the index surgery. This is a CT of this patient. You see these small air bubbles in front of the plate. This is very suspectful for a possible esophageal injury. So in that case, we went in again together with colleagues from the otorhinolaryngology. We found the place where the esophageal injury was done, and it was on the contact surface with the plate, and it was stitched. Then the patients have for 3 weeks received the food via nasogastric tube, and this patient had a good follow-up actually, but every time when you have a problem with an implant in any way, especially with plates, there is a possibility of esophageal injury, and it rises in patients which have tumors or which have infections and which have any kind of previous surgeries in the cervical spine. Yeah. This is also one complication, a patient which received winged cage with screws in the external hospital and needed to be re-intubated very quickly following the surgery. You see here a very big prevertebral swelling before the cervical spine, came to our institution on the respirator. And when we did the revision, this was our initial, what we initially saw. So we saw initially only a cage and everything looked good. But actually, when we looked then a bit proximally and distally from the cage, we have seen a very large hematoma. So in revision cases, especially which involve cervical implants on the anterior you always need to think, especially in longer constructs, on postoperative hematomas and swelling, and never inspect only the level which you've operated, but these hematomas can develop proximally and distally to the actual surgical site. And in any case of revision of anterior surgery where you have a hematoma or there is a suspicion of any kind of esophageal injury, we have this dynamic X-ray, which is in German called Breitschluck. So like during the act of swallowing, which then shows you the predisposition of the contrast and if there are any leaks around the esophagus. So when we talk about generally about graft complications, it's important to talk on adjacent segment disease or adjacent segment pathology. EO Spine proposed terms, which they divided into radiographic and clinical adjacent segment pathology. Occurs predominantly in the middle cervical region, especially in patients with pre-existing evidence of radiological degeneration in the adjacent segment. The prevalence is in the literature somewhere between 5 and 28%. Annual incidence in ACDF is around 3%, and according to some studies, total disc arthroplasties may have lower incidence. So generally, prevention strategies, careful level selection, C5, C6, and C6, 7 are the highest risk of any kind of complication, minimizing the damage to key structures as anterior longitudinal ligament, adjacent healthy disc, longus colli. Minimization of the plate length is very important in plate to disc distance, which is ideally less than 5 millimeter. Drilling the fixation holes close to fused disc space, maintenance of sagittal alignment, and clear algorithm or treatment algorithm in cases of any kind of graft dislocation. And in posterior surgery, if it is intended as a revision surgery for the dislocation or pseudoarthrosis of the ventral construct, we would not recommend to stop at C7, but always to do some kind of thoracic stabilization on T1 or T2. Generally, number of complications rises with 3 and 4 level surgeries, and it's more than 1 and 2 level surgeries. Dysphagia and dysphonia are very common and can also point out to any kind of possible graft problems, which can lead to initiation of the imaging. And risk factors generally: current smoking, previous cervical spine surgery, preoperative C2 to 7 angle, upper level surgery, multi-level surgery, opioid use, high preoperative NDI scores, and of course patients which are not compliant, because if somebody goes to do an extreme sport very early after a cervical spine surgery, there is a big chance that any kind of graft-related complication will occur. In some of these expandable cages like this, which we've started to use recently, there's also risk that you have an iatrogenic dural injury, which then manifests with large CSF leaks on the ventral side. CSF leaks on the ventral side are never to be stitched, but you usually put the hosel and fibrin glue and then put patients on the lumbar drain. And of course, immediately if it is recognized as a complication. And there are always cases of over-distraction of the graft in the operative field. And this over-distraction can actually, especially in patients with unstable cervical spine, lead to a back out and to the injury of the cervical spine, like in this patient with some horrible complications afterwards. Yeah. And of course, these are several other cases which are more related to the posterior surgery, and generally for any kind of complication algorithm. Of any kind of complications, you need to have your house-in-own algorithm. We have implanted a lot of these expandable cages. We always come back to talk about them because they are for some surgeries very good. For example, for compectomies in patients with tumors or infections. But I have a very high implant failure rate of 15% in our series. This is now 5 years ago published. Usually it's an early failure in first 3 weeks to 4 months, and usually due to over-distraction, multi-level constructs, and in poor bone, as in spinal metastasis, infection, and osteoporosis. It's interesting that we didn't find any differences in standalone cages and between cervical plating, and there's a controversy if the plating actually leads to less complications or less graft-related complications. In other series, you have 19% complication rate, and there are also researchers which published that the fusion is actually very poor with these implants. So we are not against expandable cages. We use them all the time, but a careful graft selection is something which is advised in anterior cervical surgery always, and proper choice of graft. In one survey, it has been shown that surgeons believe that graft selection affects fusion rate and affects time to fusion. And the use of cage is currently the most common structural graft component. Some 64% of surgeons use it. In the Western world, 84% are PEEK cages, and North American surgeons differ a bit because they use allograft more commonly. So general for surgery advices is to pick the proper material, height, length, intraoperative position of the graft, to check that it's always in midline, that there's a solid positioning, consider additional plating, and in cases of poor bone healing, additional BMP. Thank you.
Thank you, Mirza. Very interesting presentation. You know, I really underline what you said about expandable cylinders. I think in poor bone quality, in infection, this is a call for disaster, actually, because there is this part of the expandable cage that it's not possible to fill with bone. So better to use the titanium mesh. I think it's a very important message. So
yes.
My co-moderator, Yahya, are you there?
Yes, I want.
Yeah,
There is a question, but we can ask to the speakers some question because they were very good presentation, and I wanted to ask to the Mirza and Professor Oskar say same things. Sometimes we select mesh cage and we are trying to put some autografts. Sometimes we take some Costa graft and we put in operation area, and you said some same things, Mirza. You have any management rule? For example, if you make one level, you can put this expandable corpectomy cage, or more than 2 level, you try to put autograft, or you always try to put autograft. How is your strategy for short level corpectomy and long level corpectomy?
Well, we don't use autografts, and I think in Germany, in most of hospitals, or vast majority of surgeons don't use any kind of, like pelvis or something. What is here is bone morphogenetic proteins. People use that, or nanogel, those biologics or osteobiologics, which help fusion. And if I have 1 level surgery, I usually try, or 2 level, to use the graft. We use standardly PEEK cages. But if you have a very big osteophytes or OPLL or any kind of underlying disease where you cannot just do discectomy in 2 levels and put a cage, then we usually go for a cage. Now, expandable cages, as Alves said, are very problematic if you have any kind of poor bone, osteoporosis, any kind of it. So I think that we are still searching for the perfect implant. What I've seen in the United States, my mentor, Professor Arnautovic, does a lot of allografts. I think allografts might be a very good solution to these problems in a multi-level setting, because when he does 2 or 3 level ACDF, he always puts allograft, which is actually a cadaver bone, and he has a very good fusion results. And with this allografts, it enables you, you can cut them to the size which you need, and they come in very big sizes. It enables you to do a very good decompression of neuroforamina. So I think that's something to consider.
Yes, and this is very problematic for osteoporotic bones. When you maybe this cage, maybe 1 or 2 months later, in short time, we can see another area, knee fractures in vertebra sometimes because
Yes.
of this. And thank you, Mirza. And I want to do us to do really, it was very good presentations, and really you can show us some of the management of esophagus injury. And we have some cases, all of the cases have old history of operations, and they come to us after some accident. 2 of them is car accident, and they played injured their esophagus. And we called the thoracic surgeons when we take this case after again operations, and the thoracic surgeons take some muscles and they stitch to the esophagus with these muscles, and they make some graft around the injured area. How you approach these cases during surgery? You can say some things for that, for esophagus surgery.
Yeah. Also for the esophagus injury that happened, I think the first time we have to know the level of the injury of the esophagus. This is the injury of trauma or after surgery?
Yes,
Trauma, yeah.
after trauma. Yes,
Yeah,
during it can maybe very, very rare
yeah.
after trauma.
Very rare, yeah. Sometimes the injury of esophagus is divided into 2 parts. The first is cervical part, and the other is upper thoracic and lower cervical and upper thoracic part. And when we got the trauma of esophagus, my advice is look for the patient first, the clinical condition, and sometimes the level is need to be determined at the first time. And when we we can suspect there's an injury of esophagus when the patient, if the patient conscious, I mean, we can ask them, and they can feel burn in the neck, and then it's a breathing heavy breath in the upper chest, and then they feel like something fluid inside neck. The neck, it's flowing fluid flowing in the neck. And then my suggestion, it happened to me, but after surgery, I rather consult to ENT surgery and then do the barium barium study first and find the fluid. And then if we can find the level, if it's happen C6 to upper, we can do the long incision to explore everything inside the middle medial part of the sternocleido, along to the to down to the C6 7. But if it's happened below C6 down, we have to consult the thoracic surgery to cut the manubrium, I think. And then when we find it, they need to leave some OGT, oral gastric tube inside, because it's a bit difficult to do the suture when the esophagus is empty. So they need to put a stiff tube inside the esophageal tract, and then we can identify the wall that rupture, and then we can do the suture. But in my case, I did the suture 2-3 millimeters, and then it's open again. So I think it should be double suture, I think. But the complication of double suture also the esophagus will become stricture and give another problem. but it's very rare actually. What happened to you? Yeah. It's a
Thank
good
you.
experience
Thank
because
you.
yeah.
And
Thank you very much. Yeah.
thank
Because
you.
what makes become best surgeon is the bad experience, right? Bad
Yes, yes,
experience is the best teacher.
Can I comment on esophageal rupture?
Yes, sir.
Yeah, it's
yes.
really a very difficult to manage complication. I've seen maybe 10 or more esophageal ruptures. In two of them, one of them I remarked during the surgery. It was a trauma case, and I could repair. And then after surgery, nothing happened. This was so unique. Since the rupture was due to trauma or during the surgery of trauma, I don't know. But the other one was a previously operated patient who had gone anterior plating, and one of the screws were lost later. And then we opened the patient and saw there is a esophageal rupture. And we could manage it easily by a stitching. But as you know, the esophagus is a unique organ that there is no adventitia. There is a mucosa and muscle layer only. So even if you stitch the mucosa very well, you must keep the patient without oral nourishment, without oral feeding for long periods. And the others were with infections who were managed with months-long management techniques, because some of them would need some gastrostomy since it's not easy to feed the patient for long periods. Very, very nice lectures. I enjoyed all the speakers' talks very much.
Mehmet,
There was
should we-
one question coming written on the did you answer this on the standalone cage compared to plates preventing ASD?
Maybe Sameh, you wanna comment? I think you touched already the point.
Yeah, so I moved away from using plates 4 or 5 years ago, right? I initially, as Mirza mentioned, I was trained in North America, so I was using those allograft all the time with plates in the front because I would love to see fusion on X-rays on bone. Nothing beats bone at the end of the day. But with the new data that we see nowadays, the problem with the standalone cages in the past, because it's not fair to put all standalone cages in one sack. Because the older standalone cages were the ones with no screws up and down, were those pathetic cages, and the rate of pseudoarthrosis was really high, and you used to get more fusion as you use more plates with those. But with the newer technology, with the 0P cages, the one with divergent screws up and down, the data is very promising. So you get exactly the same fusion rate, almost the same fusion rate that you get with a plate. The incidence of subsidence is much lower than what it was with a standalone cage in the past. And also the loss of lordosis is not as bad as it was with the previous standalone cages. So to your point, I moved away from using plates for this particular reason. It takes an extra time that's totally unnecessary. We know very well from the literature nowadays that it's very well associated with postoperative dysphagia. So the newer standalone cages are definitely the way to go.
Great.
Can I give a comment?
Sure.
Yeah, I totally agree with Shame said about leaving the plot. Yeah, because I'm also 1/20 cases for cervical anterior surgery. I leaving the plates because the plate is giving so many problem like dysphagia, and the screw is distracting all the bone upside down. When we try to do the serial CT scan, and the screw of the plates, or the cage is fine and the cage is very well, but the screw come from plate, it upside down, it make destruction of the bone itself, and then the other dysphagia, and then the longer the plaits, it will be more complication. So but in my center, we don't have we have, but it's very difficult patient to afford to buy cage with with the screw inside. I mean the new producing cage, but I choose to use only P cage, but use the a bit over distraction, so it will it give the clinical patient after surgery is very well. So I also leave the plate for long times. Thank you.
One question from Hakan Karabalı, Professor Hakan Karabalı from Selçuk University, Turkey. And thank you for excellent presentation. I have one question for Dr. Rally and Ruli. What are you say for esophageal stent for repairing esophageal ruptures?
Yeah, I heard about the repairing of esophageal rupture with the stent, but I never been experienced. But it's a good choice. But it's usually done also with by ENT surgeon, I think. But if we join like we when we do the C7T1 surgery, we sometimes most of the time, I think for myself, consult with the thoracic surgery, and if we are it's doing the stent, I think if in my opinion, we have to do it with the ENT surgeon. But it's a good choice in a book also. Yeah, you're right.
In one of my cases, they used it, but it was not successful. But I guess there is not much experience collected in the literature on that.
Yes. And there is
Yes.
We should conclude the session. What do you think?
Yes, we can.
Okay, Mehmet, thank you once again for putting this together, and Yahya as well. And I'm grateful for the speakers, great presentations, and hope to see you in the next future. And Same, once again, congratulations, happy birthday.
Thank you, Oscar. Appreciate it. Thank
Happy
you.
birthday.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.
Yeah,
Good
bye
night.
bye. Yeah, thank you. Good
Goodbye.
night. Have a rest.
Bye-bye.